presentation have been taken from online available material and textbooks for educational purpose. By the end of this module, participants should be able to screen people and children living with HIV for opportunistic infections and co-infections. They should be able to diagnose and treat viral hepatitis, including hepatitis B, C, and D. Diagnose, prevent, and treat common AIDS-defining illnesses. Screen, prevent, diagnose, and treat co-infections and opportunistic infections in people and children living with HIV, and prescribe important vaccinations. So we shall be discussing about blood-borne infections, CD4 count, and its association with opportunistic infection. We shall discuss about the leucocystis pneumonia and cotrimoxazole preventive therapy, cryptococcal meningitis and treatment, mycobacterium avium complex in treatment in detail, and we shall briefly discuss about toxoplasmosis, cytomegalovirus, GI pathogens causing diarrheal diseases, candidiasis, leishmaniasis, progressive multifocal leukoencephalopathy, human herpes virus 8 causing Kaposi sarcoma, briefly. The chickenpox and shingles and acute community-acquired pneumonias will also be discussed. At the end of this presentation, we will discuss the vaccinations which can be given safely to the patients. Blood-borne infections. Blood-borne infections include hepatitis B, C, and hepatitis D. According to WHO in Pakistan, the prevalence of hepatitis B is 5 million and of hepatitis C is 10 million. Hepatitis B prevalence falls between 2 to 8% and hepatitis C prevalence is less than 2% in Pakistan. According to studies in people who inject drugs, the HPV prevalence found to be 15%. And in people who are injecting drugs and when HIV positive, the prevalence was 6%. Hepatitis C and HIV co-infection was found in 90 to 55% of patients in different studies. The major mode of transmission of hepatitis B and C in D is similar to HIV, but this is to note here that hepatitis B virus can be transmitted more effectively. For example, if we take the example of needle-stick injury, the rate of transmission of hepatitis B virus through needle-stick injury is 3%, while for hepatitis C is 3% and least is for HIV, which is 0.3%. The clinical presentation of hepatitis B varies from asymptomatic stage to permanent hepatic failure and hepatocellular carcinoma. Patients may present with cirrhosis, which can be compensated or decompensated. The signs of decompensated liver cirrhosis or chronic liver disease include presence of jaundice, presence of spider nevi, gynecomastia, dupuytrenine contracture, clubbing, palmar erythema, and signs of portal hypertension like splenomegaly, prominent veins on abdomen, umbilical protrusion, etc. Hepatitis B virus in children usually remains in high replication state and low inflammation phase, with normal or slightly raised aminotransferases. Cirrhosis and hepatocellular carcinoma is rare in children. Hepatitis B surface antigen can be sent and hepatitis B a core antibody can be sent. As you have seen in every HIV patient at baseline, this is mandatory to send hepatitis B surface antigen and hepatitis C virus antibody to diagnose the co-infections early. Then to see the state of viral replication, hepatitis B E antigen, hepatitis B E antibody, and hepatitis B viral DNA can be sent. In a patient with positive hepatitis B E antigen, the viral replication is high and there are high chances of transmission. However, if a patient has developed anti-hepatitis B E antibody, it means that the viral replication is low. SGPT can be raised in a high viral replication phase. Then ultrasound abdomen can be performed to see the splenomegaly and splenic varices and presence of cirrhosis, ascites, etc. EPRI score can be calculated to see the stage of fibrosis, which we will be discussing in next few slides. Mode of transmission for hepatitis D is similar to the mode of transmission of hepatitis B. Hepatitis D virus requires hepatitis B for its replication. Diagnosis is done through positive anti-HDV, IgG, and IgM antibodies and HDV RNA levels. Prevention is through hepatitis B vaccination and hepatitis B prevention strategies. Treatment is done with pegylated interferon alpha. Adolescents and children with chronic hepatitis B and clinical evidence of cirrhosis or cirrhosis based on non-invasive FP score more than 2 in adults should be treated regardless of ESG, hepatitis B E antigen status, and hepatitis B viral DNA levels. The recommended NRTIs for HIV and HBV co-infection are tenofovir and lamivudine. Tenofovir monotherapy for hepatitis B monoinfection has been recommended in WHO guidelines. Discontinuation of lamivudine causes the flare and reactivation of chronic active hepatitis. Hence, discontinuation of this drug should not be done even if the resistance has been documented. Similarly, if the patient who was already on tenofovir monotherapy for hepatitis B virus infection and now diagnosed with HIV co-infection, tenofovir will be continued, and this has been discussed in detail in module on ART regimen in special circumstances. Tenofovir and 3TC based or lamivudine based regimen is preferred in these patients. Infants who are born to hepatitis B surface antigen positive mothers should receive hepatitis B immunoglobulin and hepatitis B vaccine within 12 hours of delivery. Second and third doses of vaccine is dependent on the weight of infant, and in an infant who is low birth weight, the birth dose should not be counted over the 3-dose series. In infant who are more than 2 grams of weight, the second and third doses of vaccine should be administered at 1 and 6 months of age, and the initial dose given at birth is counted in a series. WHO recommends treatment in all children and adolescents who have clinical evidence of compensated or decompensated cirrhosis, regardless of their SGPT levels, hepatitis B viral DNA levels, and anti-hepatitis B E antigen status. In WHO, entecavir and tenofovir have been approved. Entecavir can be given in children who are between 2 to 17 years, and tenofovir can be given to the children between 12 to 18 years. However, in children who are co-infected with HIV, the preferred regimen is tenofovir and lamivudine-based regimen as in adults. Hepatitis C virus-related hepatic disease progresses more rapidly in patients who are co-infected with HIV. Treatment is priority. However, the treatment is complex and difficult due to lower response rates, higher risk of toxicities, increased pill burden, and overlapping toxicities and drug-drug interactions between direct-acting antivirals and ARVs. It is advisable to clinically stabilize the patient, especially who are in advanced HIV with CD4 count of less than 200 before treating hepatitis C virus. There are very potent and effective pan-genotyping direct antiviral agents available, and these are recommended for the treatment of hepatitis C virus. Now, the question is whom and when to test for hepatitis C virus. So, all the patients who are HIV positive should be checked at baseline for hepatitis C virus status with anti-HCV, and the patients who are transfusion recipients and injecting drugs, if found previously negative, should be screened yearly, and these include patients who are receiving transfusions for thalassemia. Whom to treat? WHO recommends the treatment in all adults and adolescents, patients, and children who are more than 12 years of age, irrespective of their disease stage. In children who are less than 12 years of age and with chronic hepatitis C virus infection, WHO recommends to defer the treatment until they are 12 years of age. WHO recommends different combinations of direct antiretrovirals for variable periods depending on the selected regimen. In adults who are 18 years or above without any clinical evidence of cirrhosis, Sofosbuvir can be given either with velpatasvir or declatasvir for 12 weeks, and clicapravir can be given with pibrentasvir for 8 weeks. In adults who have compensated cirrhosis, sofosbuvir can be given with velpatasvir or declatasvir for 12 weeks or for 24 weeks, or clicapravir and pibrentasvir can be given for 12 weeks. In children who are less than 12 years of age, treatment should be deferred until they are 12 years of age. But in children who are 12 to 17 years of age or who have a weight of at least 35 kg, sofosbuvir can be given in combination with ledipasvir or ribavirin or for 12 weeks or ribavirin for 24 weeks depending on the genotype. Interferon ribavirin in children with genotype 2 or 3 can be considered. However, this is not the preferred or recommended. Interferon and ribavirin combination can be considered in children who have genotype 2 or 3 and are less than 12 years of age and are having severe liver disease and are at high risk of progressive disease. For example, patients with HIV co-infection, thalassemia major, and survivors of childhood cancers. Now, what is EPRI score and what is the significance of calculating EPRI score? So EPRI score is basically the aspartate aminotransferase to platelet ratio index, which is used to measure liver fibrosis in hepatitis C. This is the non-invasive test which has replaced the liver biopsies to assess the status of fibrosis. And the scoring model is practical and easy to use. It was first developed in 2003. Now, the values range between 0.5 to more than 2, and the lower the value, lesser would be the fibrosis. For example, in a patient who has an EPRI score of 0.5, the patient will have very little or no fibrosis. If the score is 1.5 or higher, this would be the strong indicator for cirrhosis. EPRI score is calculated with the help of this formula in which in numerator AST level of patient is used, and it is divided by the lab's upper normal limit of AST level and multiplied by 100. This all figure comes in numerator and the whole figure is divided by the patient's platelet count. This is the chart which will be helpful in deciding the treatment of patients based on their EPRI score. In a patient who has less than 0.5 EPRI score, there would be no or minimal fibrosis and treatment can be deferred based on the resources available. If the EPRI score is more than 2 and patient is having either cirrhosis without decompensation or cirrhosis with decompensation, the treatment will be prioritized. Patients who are having decompensated liver disease should be referred to tertiary care hospital for management of complications. Opportunistic infections are the infections which are caused by organisms in people with weakened immunity that does not cause normally the disease in immunocompetent people, or in immunocompetent people disease is either asymptomatic or very mild. In short, these are the infections caused by organisms when they are given the opportunity. So here you can see that a CD4 count plays an important role in causing different types of opportunistic infections. In a patient with CD4 count of more than 500, the most common infections are usually community acquired. This is to note that tuberculosis can occur at any CD4 count. Now, if a person who is having CD4 count is less than 200, the common opportunistic infections include PCP or PGP, Cryptosporidium, Candida, and fungal pneumonia. In a patients with CD4 count of less than 100, toxoplasmosis, Candida, herpes simplex virus, and CMV infections are common. Cryptococcal infection and certain GI-related infections like cryptosporidia, mycospora, microsporidiasis can occur in CD4 count less than 100. In certain studies, the Mycobacterium avium complex has also been noticed in patients who have CD4 count less than 100. In patients with advanced disease with CD4 count is less than 50, the common opportunistic infections include cytomegalovirus infections, Mycobacterium avium complex infections, cryptococcus infections, and primary CNS lymphoma, which is caused by Epstein-Barr virus, are common. Here in a column on the right side, you can see the common clinical clues which can be helpful in diagnosis these infections. For example, a patient with PCP will present with hypoxia induced by activity, interstitial infiltrate, and high LDH levels. These we will be discussing in detail when we will be discussing the individual infections. The prophylaxis for a specific opportunistic infection based on CD4 count. For tuberculosis, after ruling out active tuberculosis, if LTBI or latent tuberculosis infection is present, then INH should be started or any other regimen which is recommended to treat latent TB infection should be started regardless of CD4 count. For PJP pneumonias, it is recommended to start cotrimoxazole prophylaxis if the CD4 count is less than 350. On less than 100 CD4 count, prophylaxis for toxoplasmosis is recommended. However, if the patient who is already on PCP prophylaxis with the cotrimoxazole, toxoplasmosis will be covered and no additional prophylaxis for toxoplasmosis is recommended. Although there is an increased risk of cryptococcal meningitis at this CD4 count, but there is no prophylaxis recommended. In CD4 count of less than 50, Mycobacterium avium complex prophylaxis is recommended. In a study published from Pakistan from two big setups which cater HIV population, more than 950 patients were included, and this report indicates that the most common opportunistic infection found in patients was candidiasis, followed by pneumocystis pneumonia, which was found in 16% of patients. Cryptococcal meningitis, cytomegalovirus, and toxoplasmosis are found in more than 2% of population. Herpes was common in more than 9% of patients. However, the data from this region is very limited and we need more research in this. Pneumocystis jirovecii pneumonia, previously known as PCP or pneumocystis carinii pneumonia, is a fungal infection. Previously, it was categorized as bacterial organism, but due to its close resemblance with fungi, it is now classified as fungi. The organism is present everywhere in environment. It can cause a disease which can be fatal, especially in patients with advanced HIV. However, the incidence is falling with a potent ARV and cotrimoxazole prophylaxis. It usually occurs with a CD4 count of less than 200, and in children who are less than 1 year of age, the risk of PCP is highest. Clinically, the onset of symptoms can be abrupt or insidious. Adults may present with dry cough, tachypnea, dyspnea, and hypoxia, which is usually after the activity. For example, a patient presenting to your clinic may not be hypoxic at rest, but if you ask him to walk for at least 6 minutes or you ask him to perform some activity, the saturation at room air may fall. In severe cases, cyanosis can be the presenting complaint. In mild cases, patient is usually normal, but chest symptoms worsen after exertion. And on auscultation, you may find crepitations. Children with PCP presents with vague symptoms like fever and cough, tachypnea, and dyspnea. Severity of disease varies from child to child. The non-specific symptoms include poor feeding, weight loss, mild cough, and diarrhea. Examination will reveal crepitation, respiratory distress, and hypoxia. There are certain clinical variables which, when independently present, can be used as a high chances of PCP in CLHIV uh, rather than any bacterial or community-acquired infection. And these include age less than 6 months, respiratory rate of more than 59 breaths per minute, arterial percentage of hemoglobin saturation less than 92% at room air, and absence of vomiting. Diagnosis is usually made with the tests which are helpful in diagnosing the PCP, and there are tests which are confirmatory for PCP. So the tests which are helpful in diagnosing or raising the suspicion include X-ray, which can be normal in few situations, but more typically it presents a diffuse bilateral symmetrical infiltrates, which are ground glass in nature, and they emanate from hyla in a butterfly pattern. Second thing would be hypoxia in arterial blood gas levels and more high AA gradient. Third thing is serum LDH levels and beta-D-glucane levels, which are high. BTG or beta-D-glucane is a fungal marker which is released from fungal cell wall, and its negative predictive value is more than its positive predictive value. In patients with a negative BDG, PCP can be ruled out. The confirmatory tests include demonstration of organisms in tissue, bronchoalveolar lavage, and induced sputum sample. Specialized stainings are required to see this organism, and these include GIMSA, Defcoy, Gomory's methamine silver stain, which is here GMS stain, in which the endocysts of oocysts of PCP are visible like this. And right stains can be used for identification of oocysts and trophocytes. Then immunofluorescence, which can you see here, which showing clustered cystic forms of PJP on ball sample, can be used. PCR can be used. However, the drawback of PCR is that it cannot differentiate between the infection and colonization. PCR sample is not run on sputum usually, and bowel sample is required. Most of these diagnostic or confirmatory tests are difficult to perform in our setup, hence, and are expensive too. Hence, the diagnosis is usually made on clinical grounds with the presence of high LDH, high BDG levels, hypoxia, and X-ray findings. So, if PCP is suspected, it is recommended to start the treatment empirically. Cotrimoxazole preventive therapy is recommended to prevent the infection from PJP. Now, this prophylaxis not only prevents from PJP, but it also provides cover for toxoplasma and other bacterial infections. Indications to start CPT prophylaxis include that all symptomatic patients, adult patients including pregnant females with WHO clinical stage 3 or 4 disease, should be put on CPT prophylaxis. All patients regardless of symptoms with CD4 count of less than 350 cells per cubic millimeter should be put on CPT prophylaxis. And in settings with high prevalence of malaria or severe bacterial infections like Pakistan, CPT can be considered regardless of clinical stage or CD4 count. In children and adolescents, all children and adolescents, regardless of WHO clinical stage or CDP cell count, should be put on CPT prophylaxis. Priority should be given to the children who are less than 5 years of age, regardless of their clinical stage or CD4 count, and all the children 5 years and above who have a WHO clinical stage 3 or 4 or CD4 count of less than 350 cells per cubic millimeter, and in settings with high prevalence of serious bacterial infections like Pakistan, the CPT prophylaxis can be considered in adulthood. In HIV-exposed infants, the CPT prophylaxis should be started at 4 weeks of age or at first entrance into the healthcare system, and it should be continued until HIV infection can be ruled out definitely. In case of HIV-exposed breastfeeding children of any age, it is recommended to continue CPT until HIV infection can be excluded by age-appropriate testing and at least 6 weeks after complete cessation of breastfeeding. HIV-exposed infants should continue CBT for at least the first 2 years of life, and people who are co-infected with HIV and TB should be started on CPT regardless of their CD4 cell count, and should be continued until adult or children criteria for discontinuation are met. In conditions where CTX cannot be given, for example, in severe hypersensitivity reactions, the alternate available is Depson. However, Depson is not very easily available in Pakistan, but if available, this can be used. But it should be kept in mind that it is not an effective prophylaxis for antibacterial infections and is less effective for PGP and toxoplasmosis. Now, in mild to moderate allergic reactions, it is recommended to desensitize the patient, but this should is only be performed as an inpatient. The criteria for desensitization has been discussed in detail in guideline, and it can be seen from there. What should be the doses? And for adults, a single dose of Septran double strength, or which contains 800 of cotrimoxazole and 160 of sulfamethoxazole in once daily dose, or 2 tablets of single strength tablet can be given. The other options available are alternative regimen. If the patient has anemia or mm, is on any medications which are known to cause anemia or myelosuppression. And in patients with moderate anemia or in combination with other hematotoxic drugs like zidovudine and gencyclovir, reduced dose of 400 by 80 mg can be used. This chart has been taken from our local guidelines, where you can see the different dose recommendation for children according to their weight, and this can be seen from the guideline. So I'm skipping this slide. In HIV exposed infants, the discontinuation of cotrimoxazole should be done preferably 2 years of age until the risk of HIV transmission ends or HIV infection is excluded definitely. Monitoring is recommended through clinical staging and nutritional assessment at 3 monthly intervals. In children and adolescents, this should preferably be continued till adulthood in settings like Pakistan. We have already discussed this, and the discontinuation can be considered for those who are more than or at 5 years of age if clinical, immunologic, and virological criteria are met. Clinical staging and nutritional assessment to be performed at 3 monthly intervals. In adults, including pregnant females, it is recommended to stop the cotrimoxazole who are clinically stable with the evidence of immunological recovery, that is CD4 count of more than or equal to 350 cells per cubic millimeter, and they are virologically suppressed on ART. Clinically, they should be monitored at 3 monthly interval with CBC if they are on cotrimoxazole. Persons who are living with HIV and TB, the clotrimazole should be continued until adult or children criteria for discontinuation are met. Compliance, adverse effects, viral load monitoring while on ART and ATT is recommended. The treatment of PGP pneumonia in adults depend on 2 factors. Number 1, the severity of the disease, and number 2, the oral intake of patients. So in mild to moderate diseases, and if a patient can take orally, the recommended dose of Ceftriaxone DS is 2 TDS for 21 days. If patient cannot take orally, then IV trimethoprim sulfamethoxazole can be added in 3 to 4 divided doses for 21 days of treatment. In children who are more than 2 months of age, the dosages are different according to the body weight, and IV therapy is recommended over oral. However, as an acute pneumonitis subsides, children with mild to moderate disease who do not have issues with absorption or diarrhea can be shifted to oral treatment to complete the 21-day course. In severe disease in which the hypoxia is apparent, adjunctive steroids are recommended to be started if partial pressure of oxygen is less than 70 mm at room air or AA gradient is more than 35 mm of mercury. And ideally, the dose should be given before starting the PGP treatment or within 72 hours of PGP therapy. Recommended dosages for prednisone includes 40 mg twice dose orally from day 1 to day 5. Then dose will be reduced to half in next 5 days, and from day 11 to 21, 20 mg oral dose or IV hydrocortisone at 75% of prednisolone doses are recommended to complete 21 days of therapy. Starting of ARV is recommended within 2 weeks. In mild to moderate diseases, if a patient who has mild to moderate allergic reaction, desensitization can be considered, but this should be done only as in patient setting. And if cotrimoxazole cannot be given to the patient, then alternate is Dapsone, which is less effective and also not easily available. And G6PD levels are need to be checked with it. And in patients where Dapsone or Septran both are not an option, then there will be difficulty in treating the patients because other alternative drugs are not available. Mycobacterium avium complex or MAC infection. It is caused by either Mycobacterium avium or Mycobacterium intracellular or Mycobacterium paratuberculosis. Organism is present everywhere in environment and incidence is unknown in Pakistan. It occurs usually at CD4 count of less than 50. Clinically, the patient presents with low-grade fever, night sweats, abdominal pain, diarrhea, and weight loss, and anemia, which is out of proportion to the stage of HIV. Sometimes the jaundice, hepatomegaly, splenomegaly, and lymphadenopathy can be found in adults. At times, it is clinically very difficult to differentiate this from Mycobacterium tuberculosis infections, and if suspected, then both should be treated. In disseminated Mycobacterium avium infection, hepatitis can also be present. Isolated lymphadenopathy has been noted in disseminated infections in children. Diagnosis is usually made on clinical grounds, and AFP smear and culture from tissue, sputum, bone marrow, and blood can be sent, which can grow the Mycobacterium avium complex. Gene expert is negative. And supportive tests include anemia in CBC, high alkaline phosphatase levels, low CD4 count, and CT scan typical picture of disseminated infiltrates and X-ray findings that can show bilateral infiltrates or cavitatory pneumonias or consolidation. Treatment is recommended when the clinical suspicion of MAC is high on clinical grounds and radiological findings, or the infection cannot be ruled out, or other causes of infections have been ruled out, then it is recommended to start the treatment with triple drugs, and these include either clarithromycin or azithromycin with ethambutol and rifamycin. Maintenance therapy will be continued with the same drugs. In children, in combination therapy with minimum of 2 drugs is recommended, which can be either clarithromycin or azithromycin with ethambutol. Rifamycin is not advised as rifamycin increases P450 activity, which causes the increased clearance of protease inhibitors and NNRTIs in children. Now, primary prophylaxis in adults is recommended when the CD4 count is less than 50 in adults, and in children, the age-based cutoff of CD4 count is used to start the prophylaxis. For children who are less than 1 year of age, the CD4 count cutoff is less than 750. For children who are between 1 to less than 2 years of age, cutoff of CD4 count is less than 500 cells. In patients who are more than 2 years but less than 6 years of age, cutoff for CD4 count is 75 cells. And in children who are 6 years or older, cutoff is same as for adults, that is less than 50 cells per cubic millimeter. The regimen includes azithromycin 1500 milligram once weekly in adults and azithromycin 20 mg per kg once weekly, or clarithromycin 7.5 mg per kg twice weekly in children. The cases of treatment failure has been reported, and treatment failure will be indicated with the absence of clinical response and persistence of mycobacteria after 8 to 12 weeks of starting treatment. In case of treatment failure, repeat testing for susceptibility is recommended. New drug regimen should contain two or more drugs which were not previously used and to which the isolate is susceptible, and the options which could be considered include rifabutin, amikacin, and quinolone. However, the treatment is difficult and the patient should be referred to infectious disease expert for the management of treatment failure. Mental prophylaxis can be discontinued in adults after 3 months if the CD4 count is more than 100 cells. In children who are more than 2 years of age, who are stable on ART for more than 6 months and experiencing sustained CD4 count recovery well above their age-specific target, which was used for initiation of prophylaxis, that is more than 100 cells for children who are more than 6 years, or more than 200 cells for children who are between 2 to less than 6 years of age. Children who have strep disseminated MAC and continued immunosuppression, lifelong prophylaxis is recommended. Prophylaxis should be avoided in a patient who have high suspicion of MAC. And rather than prophylaxis, treatment should be started. Otherwise, the patient will develop the resistance. Now, ARB should be started within 2 weeks of antimicrobial therapy in patients who are not already receiving the ART to avoid drug-drug interaction, illness, and to avoid increased pill burden. Secondary prophylaxis is continued with the multi-drugs which were used as a treatment, and in children who are more than 2 years of age, discontinuation can be considered when they remain asymptomatic for MAC, they are stable on ART, and who have sustained CD4 count recovery well above the age-specific targets, which was used for initiation of primary prophylaxis. Invasive fungal diseases are major contributor in mortality, especially in patients with advanced HIV. Cryptococcal meningitis is caused by a dimorphic capsular fungi which is present all over the world and is caused by Cryptococcus neoformans or KTI. The disease usually occurs when the CD4 count is less than 100. However, in a patient with CD4 count less than 200 with CNS symptoms, the suspicion should be high and cryptococcal meningitis disease should be ruled out. Clinically, the patient can present with CNS signs and symptoms or presentations outside the CNS. When the CNS is involved, patient can present with subtle symptoms like personality changes or confusions or simple headache, but the spectrum varies and patient may present with focalities, seizures, raised ICP, and space-occupying lesions. Especially in cases of IRIS, the symptoms are usually acute and severe. The typical signs and symptoms of acute meningitis are usually absent. Now, outside CNS, the cryptococcus can involve lungs, skin, liver, or any organ, and is usually disseminated when the diagnosis is made in patients with HIV. Skin lesions are presented as umbilicated skin lesions that mimic the lesions of molluscum contagiosum. Pulmonary infections is difficult to differentiate from PCP due to the presence of cough, dyspnea, and abnormal radiograph, which typically demonstrates lobar consolidation, infiltrates, or ARDS. Screening is recommended in patients with CD4 count less than 200 through serum cryptococcal antigen levels. If they turn out to be positive, then LP should be performed. In patients who have CNS symptoms and CD4 count is low, LP should be performed, and CSF opening pressure should be measured, and rapid CSF cryptococcal antigen assays should be sent. India ink is less sensitive in these conditions. Now, the diagnostic tests which are specific for cryptococcal Our diagnosis includes serum cryptococcal antigen levels that should be more than 1:4 to be positive, and CSF studies can show the mildly elevated protein levels, low to normal glucose concentrations, and variable presence of pleocytosis, which mostly consists of lymphocytes. Gram SAIN or an India ink preparation can be done if available and may demonstrate numerous yeast forms in advanced disease. CSF cultures for fungi can be sent, CSF cryptococcal antigen can be sent, and CSF cryptococcal PCR can be done, and CSF biofire can be performed. However, PCR and biofire are expensive and not easily available. Brain imaging will be helpful in diagnosing the advanced disease, and it may show cryptococcus, multiple ring enhancing lesion disseminated in white matter. Uh, Diagnosis is made on the basis of signs and symptoms, low CD4 count, and presence of serum cryptococcal antigen, CSF DR findings, India ink, and cultures. This is a picture of India ink where you can see the black rounded body surrounded by a thick capsules. This is because the India ink is not penetrated through the capsule, which is negatively charged, and it creates the halo around the wall of the yeast. This is how the brain imaging looks like in advanced cryptococcal disease. Here, these are multiple cryptococcomas with perilesional edema, and this is the here you can see it's compressing the Wilki guy, right? This picture is the presentation of cryptococcal skin disease. Here you can see the umbilicated lesions which need to be differentiated from molluscum contagiosum. The diagnosis is based again on the clinical grounds and presence of positive cryptococcal antigens, and biopsy of these lesions can be performed. Treatment is recommended whether the patient is asymptomatic or symptomatic. However, the treatment regimen slightly differs in both conditions. In a patient who is asymptomatic but with positive cryptococcal antigen, preemptive therapy is considered with high dose fluconazole in adults and in children 6 to 12 mg per kg per day. Along with flucytosine if available for 2 weeks. However, flucytosine is not available in Pakistan. Hence, the amphotericin can be considered. Now, maintenance is continued with the fluconazole 200 mg per day in adults and 6 mg per kg per day in children for total 12 weeks. If cryptococcal antigen is not available, then primary therapy can be considered if CD4 count is less than 100, depending on the suspicion of treating physician. Treatment is usually based on availability of amphotericin and flucytosine. In symptomatic adults, there are 3 phases: induction, consolidation, and maintenance phase. In induction phase, amphotericin B with high-dose fluconazole is recommended for 2 weeks, and consolidation phase is continued for 8 weeks with fluconazole. Repeated lumbar punctures are advised if intracranial pressure is high. And in disseminated or severe pulmonary disease, the regimen is same as for cryptococcal meningitis. In mild to moderate pulmonary disease, only fluconazole 400 mg per day for 6 to 12 months is recommended. There is no role of steroids or mannitol to release the raised intracranial pressure. If intracranial pressure is not getting settled with repeated LPs, then a shunt or extraventricular drain can be considered. Electrolyte and fluid management and monitoring to address the adverse effect caused by amphotericin is recommended. Now, disease is monitored through repeated CSF cultures to see the clearance and treatment success, and LP should be performed by a specialist. Cryptococcal meningitis is not a disease to be treated in OPD, so whenever it is suspected, patient should be referred for infectious disease consultation, and in cases where the disease is advanced, and patient should immediately be referred to the specialties where multidisciplinary teams comprising of neurological department, neurosurgical department, and infectious disease department are available. Secondary prophylaxis or maintenance is recommended to be continued for 12 months at least once the therapy has ended, and with the fluconazole 200 mg per day. Discontinuation can be done if a patient is stable and had been adhering to ART and antifungal for at least a year, and CD4 count has been more than 200 6 months apart. Viral load is undetectable. If the viral load facility is not available, then the CD4 count should be more than or equal to 200 uh, 6 months apart, and the patient had received at least 1 year of therapy. Secondary prophylaxis is not recommended for children, younger children, as disease is rare. In children, secondary prophylaxis can be discontinued if all of the following criteria are fulfilled. Child is more than 6 years of age, child is asymptomatic and is on more than 12 months of secondary prophylaxis, CD4 count has increased to more than 100 cells with undetectable viral load on ART at least 3 months. In all the patients, secondary prophylaxis must restart if CD4 count drops below 100 cells per cubic millimeter. Now, ART initiation is recommended to be delayed strictly in patients who are having cryptococcal meningitis because the iris caused by this disease is life-threatening, and it is the most feared complication in advanced HIV. Hence, all the efforts should be put to diagnose the cryptococcal meningitis disease before initiating of ARV, and ARV should be started only after uh, ruling out the cryptococcal disease. Now, initiation of cryptococcal disease is recommended for after 4 to 6 weeks from the initiation of antifungal therapy, according to the induction and consolidation therapy. Table has been taken from the global guidelines and can be referred to for further study. Treating physician should be aware of adverse effects associated with cotrimoxazole therapy, and he should clearly be communicating to the patient with instructions to return back to the healthcare if he or she develops any of these, especially the chances of hypersensitivity or photosensitivity should be communicated. Grade 4 reactions have also been reported. Ceftriaxone can cause nausea, vomiting, diarrhea, and pancreatitis, strep fever, headaches, and confusion. Now, the drug is known to cause the bone marrow suppression and may result in agranulocytosis, aplastic anemias, megaloblastic anemia, thrombocytopenia, etc. Drug-induced hepatitis has been reported rarely, and other side effects include interstitial nephritis, secondary rising serum creatinine. Amphotericin can cause acute kidney injury and electrolyte imbalance, especially low potassium and magnesium, fever and injection site pain and reaction. Now, CBC should be monitored with the initiation of cotrimoxazole regularly, and if the drug is supposed to cause or is suspected to cause the marrow suppression, then alternate should be considered or dosage should be reduced. Most is another infection which is caused by an intracellular protozoa Toxoplasma gondii, which is present worldwide. Transmission is through ingestion of oocysts in undercooked meat or in cat feces, and through vertical transmission in young children, which results in congenital toxoplasmosis. Now, the disease can present as primary infection or reactivation. Primary disease is more common in immunocompetent hosts, and it presents just like any other viral illness with acute fever or cervical lymphadenopathy, and is usually self-limiting. Most of the time, it is asymptomatic. The treatment is awarded only in pregnant females for acute or primary infection. Reactivation is more common in immunocompromised hosts, and PLHIV can present with CNS toxoplasmosis, CNS symptoms, space-occupying lesions, and ring-enhancing lesions. Ocular toxoplasmosis has also been seen. Retinochondroiditis, pneumonia, and other systems can also be involved, but these are rare. In children with HIV, the common presentation is with CNS symptoms, less alertness, and seizures. Diagnosis is made when the picture is compatible with the common signs and symptoms. Mass lesions present in brain imaging. Organism is detected in the sample. Usually, a brain biopsy is recommended, and tissue is stained with H&E. But this is not routinely available, and since brain biopsy is an invasive test, it should not be performed in every patient. Serologies are not very helpful, and if IgM is positive, then these needs to be interpreted carefully, and IgM avidity tests are done only in reference labs. CSF studies, however, can be performed to rule out other etiologies, and it is always recommended in a patients who are presenting with CNS symptoms with advanced HIV to look for uh, all the common etiologies which can cause CNS symptoms rather than sticking to the one diagnosis or differential diagnosis. In Pakistan, diagnosis is made on clinical grounds, etiological grounds, and after ruling out other infections in the presence of very low CD4 count. Um, this is the toxoplasmosis related necrotizing chorioretinitis. Here you can see the necrotizing lesions, and this is a brain imaging of a patient which shows complete ring enhancing lesion with perilesional edema and midline shift. And this is how the organism itself looks like. Prophylaxis is indicated in adults when CD4 count falls below 100, and children have different cutoffs according to their age. Now, patients who are already receiving cotrimoxazole for PJP prophylaxis do not require additional prophylaxis for toxoplasmosis. The alternate drugs include Dapsone with pyrimethamine and leucovorin. Treatment should be done in consultation with infectious disease specialist, and patient should immediately be referred to tertiary care facility. The available options are weight-based pyrimethamine and sulfadiazine, which is the preferred regimen, trimethoprim sulfamethoxazole, pyrimethamine and clindamycin, and CBC should be monitored weekly in patients taking pyrimethamine. Since brain biopsy is not routinely done and due to limited availability of diagnostic tests, the treatment is usually started empirically, and response is measured after 2 weeks of treatment and with the improvement in brain imaging. So if brain imaging shows improvement in mass lesions, then the treatment is continued considering it as toxoplasmosis infection. Discontinuation of primary prophylaxis is recommended in adults who have CD4 count more than 200 for more than 3 months in response to ART, or CD4 count remains high between 100 to 200 and viral load remains undetected for at least 3 to 6 months. In children, response to ART with sustained rise in CD4 percentage more than 15% for age less than 6 years and more than 200 cells for children more than 6 years. This was consolidated chart, which can be helpful in revising the initiation and discontinuation criteria in adults and children for PJP, MAC, and toxoplasmosis. Cytomegalovirus infection is caused by a DNA virus present worldwide, and route of transmissions include in utero, during infancy, early childhood, and adolescence. It has been transmitted through breast milk, saliva, sexual fluid, organ transplant, and blood transfusion products. Disease is common when CD4 count is less than 50. Clinical presentation includes the primary infection in immunocompetent host, which can present like any other viral illness and does not need any treatment, and reactivation, which is more common in immunocompromised host. Now, most common presentation in HIV patients is retinitis. However, esophagitis, colitis, hepatitis, pneumonitis, and encephalitis can also be present. In acute infection, fever, lymphadenopathy can be present like any other viral illness. Patient can present with anemia, jaundice, hepatomegaly, renal failure, lymphadenopathy, depending on the organ involved. There are two types of cytomegalovirus infection. One is megalovirus infection in which the viremia is present, and one is organ specific or organ invasive disease in which the viremia may be absent but the organism is present in tissues. In children, the disease is less common but more symptomatic and progresses rapidly uh, towards the severity. Multiple organs can be involved, and children can present with CMV retinitis. However, the other clinical picture include fever, poor weight gain, loss of developmental milestones, and other non-specific symptoms. Diagnosis is usually made on the basis of presence of inclusion bodies in tissues, presence of CMV virus in blood, which is done through PCR, PISA by appearance on eye examination, presence of ulcers on endoscopies and colonoscopies, viral picture on CSF, pancytopenia in disseminated CMVs, deranged LFTs, deranged renal function tests. On radiological grounds, in case of pneumonitis, the patient can present with bilateral infiltrates, which can mimic PJP pneumonias, and the many specific investigations which are diagnostic for cytomegalovirus are not available in Pakistan. So, the diagnosis is basically made on clinical ground and presence of CMV PCR in blood and eye examination. The differentiation between active disease and infection is difficult in an infant due to the possibility of transplacental passage of immunoglobulin. This is the PISA by appearance of CMV retinitis. Here you can see the hemorrhages with cotton wool exudates, and it gives the appearance of PISA by. These are the trans, uh, transpassing vesicles. Now, these are inclusion bodies, and these are also known as owl's-eye, and these are the basically DNA of cytomegalovirus in cells. This is how the radiology can look like with bilateral infiltrates, and this can mimic other diseases like PJP, tuberculosis, MAC, etc. The duration of treatment depends upon the site and severity of the disease. Available options are IV gencyclovir or oral valganciclovir. Disease is treated in two phases, induction and maintenance phase. And if the eye is involved, then intravitreal ganciclovir is recommended. Patients with suspected CMV should be referred to the specialist for appropriate management, and children with suspected congenital CMV should be referred to a specialist for further evaluation and management. ART should not be deferred in patients with CMV disease, and a secondary prophylaxis can be considered in consultation with the specialist. Now, in every stage 4 HIV patient, examination should be performed, and this can be sometimes helpful in identifying the opportunistic infections. Okay. Patient can present with diarrhea in advanced HIV, and the common causes include cryptosporidium, isospore, and microsporidium. So all these are present with advanced HIV disease when CD4 count is less than 100 or 50. There are different clinical presentations like cryptosporidium presents with growth and nutritional compromise in children, diarrheal illness, and sometimes cholera-like illness. And sometimes it's recurrent watery diarrhea. Isospora presents with non-bloody watery diarrhea, abdominal pain, cramping, nausea, vomiting. Microsporidium can present with diarrhea and encephalitis, and ocular symptoms have also been reported. Manifestations are different by different species, and in children, intermittent diarrhea, chronic diarrhea, or malnutrition or failure to thrive have been seen. Transmission is fecal-oral route for cryptosporidium by injection of oocyst, and especially in males having sex with males. And in isospora, injection of oocyst from contaminated food and water, and microsporidium is also transmitted through fecal-oral route. Diagnosis is done by specific microscopic examination and staining with specialized stains. For example, for cryptosporidium, acid fast staining is done. Modified acid fast staining is done to see oocyst in isospore, and light spectroscopy is performed after modified trichrome staining. Treatment is supportive, and in all cases, early initiation of ART is recommended. Scotiamoxazole orally can be given in isospora, and albendazole can be given in microsporidium. Cryptosporidium can be treated with nitazoxanide. Prevention is through good hand hygiene and early initiation of ART and avoiding of high-risk swimming exposure. The organisms are resistant to chlorination of water. In severely immunocompromised children, the chicken pox can result in complications like encephalitis, rhinosinusitis, pneumonitis, and multi-organ failure. Herpes zoster shingles more commonly occur at CD4 count less than 200, but the disease may occur at any CD4 count. ART have shown the reduction in incidence. In severely immunocompromised patients, the presentation can be with disseminated disease, encephalitis, or varicella pneumonia. Diagnosis is usually made on clinical grounds. The treatment depends on the severity of the disease and patient's ability to take the antivirals orally. Available options are acyclovir, valcyclovir, and famciclovir. So, in mild to moderate disease in adults, oral options should be given, and in severe disseminated ocular or neurological disease, life-threatening or sight-threatening disease, IV acyclovir is recommended. In children, chickenpox should be treated with IV acyclovir, especially in patients who are severely immunosuppressed and who have high fever, abdominal pain, chest symptoms, or numerous or deep necrotic or hemorrhagic skin lesions. Dose is 10 mg per kg 8 hourly in children who are less than 1 year of age. Can be used in older children as well for 7 to 10 days. If a patient improves, the therapy can be switched to oral. Therapy should be continued for 7 to 10 days provided no new lesions for 48 hours have appeared. Only mild to moderate immunosuppressed cells with mild varicella infection can be treated with oral acyclovir. IV acyclovir in severely immunocompromised children is recommended to treat shingles, especially in a patient who have extensive multidermatomal herpes zoster infection or disseminated disease or visceral involvement. Therapy should be continued till clinical improvement, and it should be followed by oral therapy. Oral acyclovir can be used in mild diseases. Prevention is through vaccination and post-exposure prophylaxis with varicella zoster specific immunoglobulin if available, or immunoglobulin within 96 hours of exposure in non-immune individuals. There should not be a delay in starting ART in these patients. Human herpes virus 8 is known to cause the Kaposi sarcoma, primary fusion lymphoma, and multicentric Castleman disease in patients with HIV. The disease can occur at any CD4 count, however, it is more common in advanced HIV. Route of transmission is unclear, but the shedding has been noted in saliva and gelatin secretion of patients who are asymptomatic. Kaposi sarcoma is presented as non-tender, hyperpigmented, macular or nodular skin lesions, and this can involve viscera like liver as well. Diagnosis is done with cytological and immunological cell markers and histopathology. Treatment is done with radiotherapy, intralesional chemotherapy, or surgical excision of localized disease. Systemic disease requires chemotherapy, and early initiation of ART is recommended. Patient should be referred to a specialist for further management. Leishmaniasis is caused by an obligate intracellular protozoa, Leishmania. This is more common in Balochistan and KPK. However, cases have been reported from Sindh, especially in Dad. Transmission is through the bite of infected sandfly. Disease is more common with advanced HIV, and in advanced HIV, there can be an atypical presentation. Different species cause diseases in different regions, and there are different presentations. The discussion of all of these is beyond the scope of this presentation. However, the CDC guidelines can be reached out for further information, or WHO guidelines can be referred. There are three types: cutaneous leishmaniasis, which is caused by Leishmania tropica; mucocutaneous leishmaniasis; and visceral leishmaniasis or Kala-Azar disease, which is caused by Leishmania zornoan in our region. Now, every patient presenting with cutaneous leishmaniasis should be looked for mucocutaneous leishmaniasis, and mucous membranes of mouth, nose should be examined. Then there is an entity which is known as post-Kala-Azar dermal leishmaniasis, which has also been reported. Kala-Azar disease or visceral leishmaniasis presents with fever, malaise, hepatosplenomegaly, moderate to severe splenomegaly, pancytopenia, and lymphadenopathy. Skin or cutaneous leishmaniasis presents like crater-like ulcers or nodules. Here you can see the very clearly demarcated crater-like ulcers with raised margins, and nodules can also be present, and these ulcers are usually present on exposed areas or periphery. Diagnosis is done by finding the organism in aspirates or bone marrow or zinc aspirates, which are known as Leishmania donovani bodies in case of visceral leishmaniasis, or LT bodies, Leishmania tropica bodies in cutaneous lesions. Diagnosis of cutaneous leishmaniasis should be considered in patients with one or more chronic skin lesions and a history of exposure in an area where transmission of leishmaniasis is endemic, and identification of organism in biopsy of ulcers and nodules. The histopathology has typical picture of chronic granulomatous inflammation and foreign body like giant cell. The treatment depends on the type of leishmaniasis present, and duration of therapy differs with the presentation. In case of cutaneous leishmaniasis, the treatment is different for simple and diffuse leishmaniasis. Available options in Pakistan include miltefosine and conventional amphotericin B, pentavalent antimony or sodium sevogluconate. Management needs specialist consultation, and patient should be referred. ARB is not recommended to be delayed in case of leishmaniasis. Another presentation in an advanced HIV is due to the progressive multifocal leukoencephalopathy caused by JC virus, which is present worldwide. The virus is acquired as a primary infection in childhood, and children remain asymptomatic. Clinically, the onset is insidious and may take several weeks to be manifesting, and clinical presentation mainly depends upon the area of CNS involved. Presence of focal demyelination and any area of brain can be involved. Differential diagnoses include HIV encephalopathy, Hand syndrome, and other infections, which can cause non-space occupying lesions. Diagnosis is done on clinical grounds with low CD4 count and brain imaging showing non-space occupying white matter lesions. PCR is not routinely available, however, can be performed in CSF. Brain biopsy, although is gold standard, but it is not feasible to perform brain biopsy in every patient. So, the diagnosis is made on clinical grounds. It is recommended to rule out other infections which can cause the similar presentation. There is no specific treatment, and immediate initiation of ART and restoration of immunity is recommended. However, the prognosis is still not very good even after starting ART. Candidiasis is one of the common presentations in patients with HIV, and it is most commonly caused by Candida albicans. The disease can manifest as oropharyngeal and esophageal candidiasis and vaginal candidiasis in females. Candidiasis in children with HIV is usually non-responding to the standard therapy. The disease is a marker of advanced HIV, and diagnosis is usually done on clinical examination with the background history of dysphagia and oral thrush. The close referential is oral varicose leukoplakia. Now, treatment options are available are oral or IV fluconazole. Dosages is different and duration of treatment is different. For oropharyngeal candidiasis, fluconazole has to be given for 7 to 14 days in a dose of 100 to 200 mg per day. Esophageal candidiasis is treated with higher doses of fluconazole for 14 to 21 days. And Candida vaginitis is treated with oral fluconazole 150 mg single dose, which can be repeated in severe disease for 2 to 3 doses. And local intravaginal topical therapy with other antifungals can be given for 3 to 7 days as suppositories. Delay in ARV is not recommended. In a patient presenting with advanced HIV and there is an obvious mucositis oral thrush and he is giving the history of a dysphagia, the treatment should be done as esophageal candidiasis. Common community-acquired infections like malaria, enteric, dengue, and COVID and influenza are recommended to be treated as in non-HIV patients. However, while treating malaria with antimalarials, it should be considered that these drugs have significant drug-drug interaction with protease inhibitors, efavirenz, and nevirapine. In patients who are having COVID, antiretroviral therapy and opportunistic infection prophylaxis should be continued in all patients, and change in ARV or treatment interruption should not be done without ID expert consultation. Routine vaccinations according to EPI schedule are recommended in children who are HIV exposed and in young adults with HIV. As a general rule, live vaccines are contraindicated. The details of vaccine schedule in children, indication and contraindications are discussed in guidelines. Vaccines can be divided in children into those who are included in EPI schedule and those who are non-EPI vaccine but are still recommended and can be considered. There are vaccines which can be given and should be given to every patient regardless of their HIV status, and these include oral and injectable polio vaccine, pentavalent vaccine, pneumococcal conjugate vaccine, typhoid conjugate vaccine, COVID vaccine, meningococcal vaccine, killed influenza vaccine, and hepatitis A vaccine. BCG can be given to a child who is already on ART, doing clinically well, immunologically stable, and TB has been ruled out. Measles containing vaccines can be given in children without severe immunosuppression. Now, BCG vaccine cannot be given in child in which the infection has not been ruled out and in infants who have unknown HIV status. Similarly, measles vaccine and rotavirus vaccine are contraindicated in children who have severe immunosuppression, which is shown by CD4 percentage of less than or equal to 10 or CD4 count of less than 200. Varicella vaccine cannot be given as this is the live vaccine, and live influenza vaccines are also contraindicated. Hepatitis B virus, human papilloma virus, hepatitis A vaccine, especially in MSIM, are safe to administer. Similarly, tetanus, polysaccharide and conjugated pneumococcal vaccine, inactivated influenza vaccine, COVID and meningococcal vaccine should be given to the patients with HIV. Now, a recap what we have learned in this module. So, HIV is associated with other co-infections like TB, sexually transmitted infections, and bloodborne infections. Immunocompromised state of PNHIV adults in pediatric population renders them at increased risk of serious opportunistic infections. Mostly opportunistic infections occur at CD4 count less than or equal to 350, and the cutoff values of CD4 count are helpful in identifying the offending pathogen and deciding the preventive therapy. Bloodborne infections, which include hepatitis B, C, and D, are transmitted through similar routes and should be managed. Delay in management increases the risk of severe liver disease. In patients with hepatitis B virus, recommended preferred regimen is tenofovir and lamivudine based. Newer direct antiviral agents are more successful in achieving a sustained viral response in hepatitis C HIV co-infection. However, drug-drug interactions and monitoring while on ribavirin-containing regimen is recommended. This is to note here that ribavirin is contraindicated in pregnant females. Candidiasis is usually caused by Candida albicans and should be treated with fluconazole. Common opportunistic infections requiring primary prophylaxis include PJP, toxoplasmosis, tuberculosis, and Mycobacterium avium complex. CPT is indicated in all symptomatic patients in WHO stage 3 and 4 and in the patients regardless of symptoms with CD4 count less than 350 if they are children. Dosage differ in adults and children. Cotrimoxazole prophylaxis prevents pneumocystis cervicae, pneumonia, toxoplasmosis, and many bacterial infections which cause GI disease and also malaria. Discontinuation of cotrimoxazole should be done according to the defined criteria in adults and pediatric population. MAC prophylaxis is considered below 100 CD4 count. The disease can present in disseminated infection. Currently, trimethoprim sulfamethoxazole is only available option for PJP prophylaxis in Pakistan. Trimethoprim sulfamethoxazole should not be given in patients with severe allergic reactions. Treatment of severe PJP, cytomegalovirus, or cryptococcal meningitis, toxoplasmosis, leishmaniasis should be done in tertiary care hospitals. Cryptosporidia, microsporidia, and isosporiasis, Kaposi sarcoma, or PMLE improve with early initiation of ART. Cryptococcal meningitis has high mortality and can give life-threatening illness if missed at the time of initiation of ARB. Management of community-acquired infections is similar to uninfected population. Delay in initiating ARV is recommended in cryptococcal meningitis, toxoplasmosis, encephalitis, and tuberculosis. The pre-HIV should be evaluated at all stages of care and vaccinated appropriately. The same recommendations stand for children. Pneumococcal killed influenza, oral polio, injectable polio vaccine, pentavalent vaccine, meningococcal vaccine, tetanus, hepatitis B, human papillomavirus, and COVID vaccines can safely be administered to all the patients infected with HIV. BCG, rotavirus vaccine, varicella vaccines are contraindicated in some immunocompromised children.
Module 9 HIV co-infectants. Sexually transmitted infections or STIs in people living with HIV, Part 1. This module has been divided into two parts, and in this module we will learn importance of sexually transmitted infections in people living with HIV, different terms used for these infections, venereal diseases, sexually transmitted diseases, sexually transmitted infections, and reproductive tract infections. Classifications of STI on syndromic basis and on etiological basis, common symptoms and signs of STIs and its epidemiology, how to assess the risk of STI in man and woman, understand relationship between HIV and STIs in people living with HIV, importance of screening of STI in people living with HIV, and syndromic management of common syndrome. People living with HIV are disproportionately affected by STIs due to similar mode of transmission and risk factors. An HIV-positive person may have one or more than one STI at a time. STIs in people living with HIV may have atypical presentation and can cause significant morbidity and mortality if not diagnosed and treated at earlier stages. HIV can accelerate the disease process of other STIs and vice versa. STIs are frequently asymptomatic, therefore all people living with HIV need to be screened for STIs at initial evaluation and periodically. Management of STI is an integral part of HIV care and treatment services. Different terms are used for these infections, and terminology has evolved from venereal diseases or VDs to sexually transmitted diseases or STDs and sexually transmitted infections or STIs. VDs is the old term used for this group of infections, which was changed and they were known as STDs. Since many STDs don't have symptoms, therefore new term used for these infections is sexually transmitted infections or STIs. Sexually transmitted infections or STIs are defined as a group of infections which are mainly transmitted through sexual contact. Although some of these infections may also be transmitted through other modes of transmission, such as transfusion of infected blood, reuse of syringes or needles, or from infected mother to her baby. But as sexual transmission is epidemiologically significant, therefore they are classified as STIs. We must also define other related terms frequently used: reproductive tract infections or RTIs. It's a broader term and includes STIs, endogenous infections such as bacterial vaginosis, and iatrogenic infections associated with unsafe abortions, unsafe delivery practices, medical interventions, and pelvic examination. The term sexually transmitted infections refers to mode of transmission, while the term reproductive tract infections or RTI refers to site of infection. More than 30 microorganisms or pathogens, including bacteria, viruses, fungi, and parasites, are known to be transmitted through sexual contact. But only 8 pathogens are responsible for high incidence of STIs. 4 pathogens cause curative infections or diseases, and other 4 cause non-curable infections. Curable STIs include syphilis, gonorrhea, chlamydia, and trichomoniasis, and non-curable STI include herpes simplex, human papillomavirus infection, hepatitis B infection, and AIDS caused by HIV virus. Some old STIs, such as chancroid and nymphophobia, used to be common, have almost disappeared due to changing epidemiology. New emerging pathogens are frequently diagnosed, such as Mycoplasma genitalium, which causes non-gonococcal, non-chlamydial urethritis in men, and cervicide in women, and rectal infection in men and women. Besides 8 common STIs, there are 2 common reproductive tract infections: bacterial vaginosis and candidiasis. Majority of STIs are asymptomatic, particularly in women. Symptoms and signs of STIs are easy to recognize. Common symptoms include urethral discharge in men, vaginal discharge in women, genital ulcer in men and women, rectal discharge in men and women, and genital growth vesicles in both men and women. Common symptoms and signs of STIs in newborn babies include low birth weight babies, eye infection, ophthalmia neonatorum, lung infection, chlamydial pneumonia, congenital syphilis, deformed bones, severe anemia, enlarged liver and spleen, skin generalized rashes, neurological problems, blindness and deafness, meningitis, blisters, fevers. Classification of STIs. STIs can be classified on etiological basis and serologic basis. Etiological classification of STIs include bacterial infections, viral infections, and parasitic infections. Bacterial STIs include gonorrhea, caused by Neisseria gonorrhoeae, a gram-negative bacteria. Chlamydia, again caused by Chlamydia trachomatis, an intracellular gram-negative bacteria. Syphilis, caused by a spirochete, Trypnoma pallidum. An emerging new pathogen, Mycoplasma genitalium, causing non-gonococcal, non-chlamydial urethritis in men and cervicitis in women. Viral STIs include AIDS caused by human immunodeficiency virus or HIV, genital herpes caused by herpes simplex virus 1 and 2, anogenital warts caused by human papillomavirus or HPV virus, and hepatitis B infection caused by hepatitis B virus. Parasitic STI include vaginal trichomoniasis caused by Trichomona vaginalis. Syndromic classification of STIs. On syndromic methods, STIs are classified as urethral discharge syndrome in men caused by gonorrhea and chlamydia in case of recurrent persistent infection by Mycoplasma genitalium. Vaginal discharge syndrome in women caused by gonorrhea, chlamydia, trichomoniasis, bacterial vaginosis, and candidiasis. Similarly, if recurrent persistent infection which is caused by Mycoplasma genitalium. Genital ulcer syndrome in men and women is caused by primary syphilis, chancroid, and genital herpes. Chancroid has become rare nowadays. Rectal discharge syndrome in men and women is caused by gonorrhea, chlamydia, rectal herpes, and non-gonococcal non-chlamydian proctitis that are caused by Mycoplasma genitalium. Lower abdominal pain or pelvic inflammatory disease or PID caused by gonorrhea, chlamydia, non-gonococcal non-chlamydian sinusitis, trichomoniasis, and bacterial vaginosis. Screening of people living with HIV for STIs. STIs are often asymptomatic. It is very necessary to diagnose and treat asymptomatic STI in people living with HIV at earlier stages to prevent complications. Therefore, screening of people living with HIV for STI is very necessary at time of first evaluation and periodically. Routine STI screening in people living with HIV. Common STIs to be screened include syphilis, hepatitis B, hepatitis C also, although it's not STI, gonorrhea, chlamydia. In women with high-risk factors, Trichomona vaginalis, HPV high-risk type 16 and 18, herpes simplex routinely screening is not recommended. However, HSV type specific antibody tests can be considered. STI screening methods. Screening methods include blood tests and non-blood tests. Blood tests include syphilis, serological test for syphilis, RPR and DPHA, hepatitis B, HPS-AG, a surface antigen, hepatitis C, anti-hepatitis C antibody tests. Non-blood STI screening tests include molecular tests, that is nucleic acid amplification tests or NAAT, or gene expert tests for Neisseria temori and Chlamydia trachomatis. The specimen used for these tests include anti-cervical swab in women and urethral swab in men, or even urine sample can be used for this test. T. vaginalis, that is Trichomona vaginalis, breakdown, and STV-associated disease in women, Pap smear, cervical cytology, and high-risk HPV-60 and 80 nucleic acid amplification tests. Syndromic management of STIs. WHO recommends syndromic and enhanced syndromic management of STIs in resource-poor settings. Syndromic management is based on identification of a consistent group of symptoms and signs and provision of treatment that deals with majority of organisms responsible for each syndrome. For syndromic management, no diagnostic tests are required, and syndromic diagnosis is made on the basis of history and clinical examination alone. And specific flowcharts guide the care providers stepwise to implement syndromic management. Why syndromic management? Etiological diagnosis requires sophisticated and costly diagnostic tests, which may not be available in resource-poor settings or may not be affordable. It may delay the treatment because results are available after some time, depending on nature of tests. Again, reliability of test results vary from laboratory to laboratory. Advantages and disadvantages of syndromic management. Advantages include easy to manage STI patients in resource-poor settings. Treatment can be started immediately. No need to wait for results of diagnostic tests. Any health worker with some fairly technology exists as syndromic methods. Following are the decided advantages of syndromic management. Number one, asymptomatic patients cannot be treated on syndromic basis. Again, there is low sensitivity of this method or approach, especially in women. Syndromic management of STI requires more drugs. Enhanced syndromic management is a new approach recommended by the WHO. This is integration of diagnostic tests with syndromic management to improve quality of care. Diagnostic tests include molecular tests, rapid tests, and point of care tests. If these tests are available in the health facility, they can be integrated in the syndromic management to improve the quality of care. Syndromic management of STI is a comprehensive package, which includes syndromic diagnosis, antibiotic treatment, health education and counseling, partner motivation, HIV testing, and follow-up. Different flow charts guide the care providers to manage STI treatments on syndromic basis. Each flow chart has 4 basic boxes, including clinical problem box, clinical examination box, box, and backup box. Syndromic management steps. There are 10 steps to manage STI on syndromic basis. Step 1. Take comprehensive medical history, including sexual history, to assess risk of STIs, ensuring privacy and confidentiality. History should be taken in a non-judgmental way, using culturally and socially acceptable terms. Perform a thorough clinical examination, including general examination, oral, genital, and rectal examination. Collect the specimen at time of clinical examination if facilities for tests are available. That is enhanced syndromic management. Always examine female patient with vaginal speculum if facilities exist. Establish syndromic diagnosis on basis of medical history and clinical examination. Perform available diagnostic tests if facilities for STI testing exist. Provide appropriate treatment for all patients responsible for syndrome. Use WHO recommended drugs as suggested in new national or WHO guidelines. Step 6. Educate and counsel the patient on STI and of risk reduction and behavior change. Answer the questions and concerns of the patient. Condom promotion is an important part of STI management on syndromic basis. Educate the patient on consistent and proper condom use and provide free condoms. Partner treatment is a very important component of STI management. Patients should be informed about the importance of partner treatment and should be encouraged to assist the partner treatment. Early step 9. Every STI patient needs to be tested for HIV. Offer HIV test and conduct pre-test counseling. Perform HIV testing and rapid testing according to WHO guidelines. Step 10. Follow. Ask the patient to return after 1 week. Take comprehensive history and perform clinical examination to diagnose persistent or recurrent infection.
I am Dr. Shaina Qayyum. I am going to talk about TB and HIV co-infection. It is the part of the training manual for ART center staff. At the end of the session, the participants will know why it is important to learn about TB and HIV co-infection, how TB is spread, what is the natural history of TB infection and TB disease, how to deal with TB in PLHIVs, the 3 I's, the intensify case finding in PLHIV, identification of TB presumptives in PLHIV, diagnosis of TB in PLHIV adults as well as in children. Also learn how to ensure high quality anti-tuberculosis treatment in PLHIVs. This will include the management of drug sensitive TB, management of drug resistant tuberculosis, Principle of management of TB in PLHIVs will special consideration in giving anti-TB drugs with ART, when to start ART with ATT, and what are the drug interactions. We'll also learn management of side effects of ATT. We will also talk about isoniazid preventive therapy for PLHIVs and what is IRIS, that is the immunoreconstitution inflammatory syndromes, which is associated with ART and ATT co-treatment and how it should be managed. Why TB HIV co-infection is important? It is known that drugs, they are strongly linked. TB HIV are strongly linked, and it is estimated that persons living with HIV, especially which have low CD4 count, accounts for 19-fold increased risk of developing active TB compared to the persons who are HIV negative. TB is a leading cause of death among people living in HIV, and it accounts for about 1 in 5 HIV related deaths globally. Now, WHO introduced a package called Collaborative TB HIV Activities in 2004, and it is progressively implemented, and it has shown to contribute an estimated 1.3 million lives saved between 2005 and 2011. And we know that people living with HIV are also vulnerable to the DRTB infection. There are several epidemiological reasons that MDR and XDR-TB may be associated with HIV. TB is caused by a bacteria called Mycobacterium tuberculosis. Now, how it spreads? There is a source of infection. This is a person who is suffering from tuberculosis and who is expelling bacteria, especially when he is coughing. Bacteria are also delivered to the atmosphere. This is the medium of infection. Now, the bacteria which are in the air are inhaled by the healthy persons who get the infection, and if the patient's immunity is low, then the infection leads to disease. TB transmission depends on infectiousness of the person with TB disease, that is the dose he is putting into the atmosphere, environment in which the exposure is occurring, the length of exposure, and the virulence of the tuberculous bacteria. Now, what happens when a person is exposed to Mycobacterium, that is tuberculosis germs? He may get infection or he may not get infection. Now, if he is infected, he gets infection. The infection may clear on its own, or the bacteria can get walled off into the body and they can remain dormant for years. That is the stage we called latent tuberculosis. And at this stage, that IGRA and tuberculin tests are positive. And now the infection can progress to disease if the patient's immunity is low. This can lead to primary tuberculosis, and then this primary tuberculosis can progress to progressive disease, which can occur in lungs, which is the major portal of entry, or it may, through blood, can spread to the other parts of the body that we called extrapulmonary tuberculosis. Management of tuberculosis in PLHIV is done under 3 I's. First I is intensify TB case finding and ensuring high quality anti-tuberculous treatment in PLHIVs. Second I is initiation of TB preventive therapy with isoniazid and early antiretroviral therapy. Third I is infection control of TB at healthcare facilities as well as at gatherings. Now the first I, intensify TB case finding. The first step is identification of presumptive. Presumptive of TB is a patient who presents with symptoms or sign of tuberculosis. These includes patient with cough for more than 2 weeks, and if the cough is for less than 2 weeks, they present with one of the following symptoms, that is blood-stained sputum, fever usually at night, weight loss. Then it also includes the history of previous TB treatment or TB history in the family. Then the X-ray test suggesting tuberculosis. And then if there are X-rays finding on the screening, uh, they also include the presumptive TB case, and these patients may be asymptomatic. The signs that were discussed earlier were the signs of pulmonary tuberculosis, but the extrapulmonary tuberculosis is more common than the ordinary persons in PLHIVs, and approximately 30% of cases which presents are extrapulmonary tuberculosis. The extrapulmonary tuberculosis are the any bacterially confirmed or clinically diagnosed case involving TB in any organs other than lungs. This may include pleura, lymph nodes, intestines, genitourinary tract, bone and joint, meninges and brain, etc. TB can involve any part of the body. The person with extrapulmonary tuberculosis will have the symptoms related to the organ involved, along with the constitutional symptoms. So, if he is having TB lymphadenitis, he will present with enlarged lymph nodes with or without sinuses. If he is having pleural tuberculosis, he will have chest pain and may have breathlessness, that is called dyspnea. If he is having spinal tuberculosis, he will have backache or maybe deformity of his spine. If joints and bones are involved due to tuberculosis, then there may be pain and swelling of the relevant joint. If there is TB meningitis, then there will be sign of raised intracranial pressure like irritability, headache, vomiting, stiffness of neck, and mental confusion. Kidney tuberculosis or the renal tuberculosis may present with paleness hematuria or pyuria. Genitourinary tuberculosis may present with infertility and menstrual disorders. Now, how TB is diagnosed? Since pulmonary tuberculosis is more common, the most common specimen that is used for diagnosis is sputum. Now, how sputum is collected? You ask the patient to rinse the mouth, then he has to breathe in and out 2 to 3 times, and then with the force effort, he coughs and brings out the sputum, which is taken into a container, and then the container is given to the person who take it for the testing into the laboratory. Now, what are the prerequisites for collection of sputum? We need a laboratory request form which is properly filled. The containers which are used to collect sputum are properly labeled. We test 2 specimens of sputum for the diagnosis. One is called the spot specimen, which is collected when the patient is first identified as TB presumptive by the healthcare provider. And second specimen is the morning specimen, which is collected at the home, and it is the early morning specimens collected after the first specimen is given to the laboratory, and this is also given to the laboratory the next day. But if the patient is living far flung from the laboratory, then another technique which is called front loaded technique is used, and this is when 2 specimens are collected at 1 hour apart. So we need 2 specimens for the diagnosis of pulmonary tuberculosis. The specimen required for the diagnosis of extrapulmonary tuberculosis can be obtained by collection of excretion, that is urine or stool, then the aspiration of the secretions like cerebrospinal fluid and pleural fluid. Then we can do the biopsy uh, and collect the tissue sample, and we can go for the surgical excision to obtain the part of the organ for diagnosis. Now, many tests are done for the diagnosis of tuberculosis, but only bacteriological diagnosis is the confirmed test for tuberculosis. Other investigations are suggestive and are interpreted in the light of clinical history. The tests used for bacteriological diagnosis are the AFB smear, but it has a detection limit for about 50,000 per ml. Then there is a molecular test, the gene expert test. It has a detection limit of 100 and 150 per ml. The line probe assay, which is again have the similar detection limit, and the culture, which is the gold standard, is the detection limit of 10 to 100. The test which suggests the clinical diagnosis are histopathological and the X-ray, and the tests which are used to diagnose TB infection. Mind it, it is not the disease, it is the TB infection, are the tuberculin test and the IGRA, which is interferon gamma release assay testing. And there are other non-specific tests available in the market, that is serological test, the CBC and ESR, but these are no more used and they are not recommended. Diagnosis of tuberculosis in children is even more difficult because they are not able to bring out sputum. So it is based on the history and examination, and it has a beautiful scoring chart has been introduced by the Pakistan Pediatric Association for the diagnosis of tuberculosis. This includes many clinical features like age, history of contact, presence of BCG scar, history of measles or whooping cough, the immunocompromised or immunosuppressed state, the protein caloric malnutrition, then the physical examination may be suggestive of tuberculosis or radiological finding if the X-ray is possible, the tuberculin test if facilities are available, and the histopathological findings, and of course gene expert findings also. So on the basis of it, a score is given to the individual finding, and then the aggregate of score is interpreted. If the score is 0 to 2, it is unlikely TB. If it is between 3 and 4, it is possible TB. It is 5 or 6, then there may be a reason to start tuberculosis treatment. And if the 7 or more, then the TB treatment is started. Patients living with HIV are immunosuppressed and have a high risk of tuberculosis. And sometimes it is very difficult to distinguish between tuberculosis and the other chest infections in the persons living with HIV. When the HIV is in early stage, the problem is less difficult and it can be as same as the person who is not living with HIV. But when the patient is having advanced HIV, then the disseminated disease and the extrapulmonary tuberculosis are more common, and the extrapulmonary tuberculosis that are presenting in the patients with HIV are lymphadenitis, pleural effusion, pericarditis, and the miliary disease, and of course the meningitis. The clinical presentations in the persons living with HIV can be different from the persons living with who are not living with HIV. Now, how the presentations are different in patients living with HIV? In the case of pulmonary tuberculosis, the smear negative TB is more common in persons compared to the persons who are not having HIV. The X-ray patterns are different, especially in the advanced HIV infection. They can present with hilar lymphadenopathy. There are more common interstitial infiltrates, especially in the lower zone. This is also atypical. And then the presence of cavities or fibrosis in patients living with HIV are less common. And the infiltrates which are present in the persons living with HIV are more common in the lower zone as compared to the upper zone, which is the case in persons not having HIV. So if we summarize, the features of pulmonary tuberculosis depends on the stage of HIV infection. The early stage of HIV infection, the pictures are similar to the persons who are not having HIV, but in the later stage of the disease, the typical picture converts to atypical presentation. Among the clinical picture, it resembles post-primary tuberculosis. At the early stage, the sputum results are often positive and the X-ray findings can have cavities, but at the later stage of HIV infection, it resembles primary tuberculosis. The smear results are often negative, and the infiltrates without cavities are more evident on X-ray. Continuing the first I, we have to ensure high quality anti-tuberculosis treatment in persons living with HIV. Now, what are the predeterminants of management of tuberculosis? It depends on the anatomical site, which is divided into pulmonary tuberculosis and the extrapulmonary tuberculosis. Then the stage of disease of progression, that is whether we are managing latent tuberculosis or tuberculosis disease, and the type of organisms that are involved, whether we are dealing with the drug sensitive TB or the drug resistance tuberculosis. Treatment of drug sensitive tuberculosis depends on the type of patient. Now, the type of patient is decided on the basis of treatment history, whether this is a new case or a previously treated case. A new case is defined as a person who has taken treatment for less than 1 month or has taken no treatment. The previously treated patients are the ones who have received any course of treatment for more than 1 month. Previously treated patients are again subtyped as relapse. The person who has been previously treated for tuberculosis and was declared cured or treatment completed at the end of their most recent course and now are again diagnosed with tuberculosis. Then the person who are defined as treatment after failure are the one who have been previously treated for tuberculosis and whose treatment failed at the end of their most recent course. The treatment after loss to follow-up are the patient who have come for treatment after an interval of more than 8 weeks, and the other are the persons who never fit in any treatment, and the person with the unknown previous treatment history are the one who are not listed above. Now, what regimen to give for drug sensitive TB depends on the patient clinical history, his bacteriological status, and if the drug sensitivity result are available. So in the case of new patient or a previously tuberculosis case who is bacteriological positive and we know that his rifampicin status is sensitive, his INS status is sensitive or is not known, then he is given for 4 drug combination for 2 months and 2 drugs combination for 4 months. If you note that there is a prefix number that indicates the number of months that particular regimen is given. Now, if the patient is bacteriologically negative, we don't know the drug sensitivity status, then again the same regimen is recommended for the new and the previously treated cases. Now, if we have previously treated case and he is bacteriological positive, he is rifampicin sensitive, and his INH status and fluoroquinolone status is not known, but he is AFP smear status for the last 2 months is positive, then he is given 6 month 4 drug combination. If we know the rifampicin status, which is sensitive, but INH is resistant, and we don't know the fluoroquinolone status or the fluoroquinolone is resistant, then again we give 4 drug combination for 6 months. If we know the previously treated case status, who is bacteriologically positive, his rifampicin sensitive and his fluoroquinolone sensitive, but his INH status is known and is INH resistant, then we give 4 drugs combination for 6 months along with levofloxacin. So, what are the principles of treatment of tuberculosis and in HIV patient? The patient with HIV should receive at least 6 months treatment containing rifampicin. Now, we have to decide when to start ARVs, and we have to consider drug-drug interaction between anti-tuberculosis treatment and the antiretroviral drugs. So when to start anti-TB treatment in and ART on the patient who are having TB HIV co-infection and are not yet on ART. It is recommended that anti-TB treatment should be started immediately. ART should be started when the anti-TB medicines are tolerated, which is possibly after 2 weeks, and should be started within 8 weeks. However, when the patient is having TB meningitis or severe form of tuberculosis, then ART should not be started up to the 8 weeks of his starting ATT. On the other hand, if the CD4 count in a patient is very low or the patient is having MDR-TB, then the antiretroviral treatment should be started within first 2 weeks of diagnosis. We have to closely monitor these patients for iris. If the patient is diagnosed for tuberculosis when he is already on antiretroviral treatment, then we have to start anti-TB treatment immediately, and we have to continue antiretroviral therapy, and we can do the required adjustment in the regimen of antiretroviral treatment based on the drug interaction. We have to closely monitor these cases for iris. When patients are having uh, co-treatment with tuberculosis and HIV, they require close monitoring. This is the chart which shows the drug interaction between the ATT and the ART, and you can very well appreciate that the anti-TB drugs, ethambutol, isoniazid, and pyrazinamide, can be taken safely with most of the antiretroviral drugs, but it is the rifampicin which is the most potent anti-TB drugs used for the first line treatment that needs to be used with caution. So there are certain antiretroviral drugs which should not be given as a combination when rifampicin is used, and there are certain antiretroviral drugs which can be used with caution when given with anti-TB treatment, and there are certain antiretroviral drugs which can be used safely. So we have to suggest a combination of antiretroviral drugs which is safely used with rifampicin. Anti-TB drugs are mostly well tolerated, but less than 5% of the patients may develop side effects due to the anti-TB treatment. So there are classified as minor side effects and the major side effects. The minor side effects includes the anorexia, nausea, mild abdominal pain. This can be caused due to rifampicin and pyrazinamide. This can be very well adjusted by giving anti-TB treatment last thing at night. Then the patient may experience joint pain, which is mostly due to the pyrazinamide and can be very well managed by giving aspirins. Then patient may experience itching and can be very well managed by giving antihistamine. There can be burning sensation in hands and feet that is due to the isoniazid. So giving pyridoxine along with anti-TB treatment can very well manage this minor side effect. And there is change in color of urine up to the red or orange, which is due to rifampicin excretion in the urine. Only reassurance is beneficial when this happens. All these side effects can be very well managed at the ART center as an outpatient. And the ART centers are now considered as BMU, so they are equipped to manage minor side effects. When the patient develops major side effect, then he needs to be referred to a TB specialist. Now, the major side effects can be skin reactions. That includes the skin rashes with fever or mucosal involvement. Any drugs can be possible for this condition. Then patient can develop hepatitis, patient can develop severe gastritis, patient can develop peripheral neuritis, patient can have visual impairment, and patient can have arthritis. Now, how this skin reaction is different? This patient have itching, rash along with systemic symptoms. We have to stop all anti-TB drugs in this case. Then patient can have hepatitis. This presents with jaundice also along with vomiting and nausea. And we have to stop all the drugs except ethambutol. All drugs can be responsible for this side effects. Gastritis can be caused due to rifampicin and pyrazinamide. So we have to stop these drugs in case of gastritis. Peripheral neuritis presenting with paresthesia of feet and hands can, even if you are giving pyridoxine, usually INH is responsible, but we have to stop INH in few cases. Then visual impairment usually occurs due to ethambutol. We have to stop the responsible drug and refer this case to the specialist for modifying the regimens. Arthritis can present like a gout and can like SLE, and we have to stop the responsible drug, and again we have to refer him or her to a specialist for the modification of the treatment regimen. So in case of minor side effects, we need not stop the drug, but in case of major side effect, we have to stop the responsible drug and have to redecide the regimen. In order to do that, we have to refer the patient to the TB specialist. When we are dealing with drug-resistant tuberculosis, we have to consider few definitions. One is monodrug resistance. Since we are using the molecular test, we can detect molecular resistance with rifampicin by using gene expert testing, with INH using LIPA testing, and fluoroquinolone with the again the by the molecular testing. Then we can have MDR-TB. Now, MDR-TB is defined as resistant to two most potent drugs, that is rifampicin and isoniazid. Then we can have polydrug resistance, which is more than one drug resistant, but in this case, either rifampicin or INH is sensitive. Then we have XDR-TB, that is resistant to fluoroquinolone and at least one of the second line injectable drugs, but this definition is also modified now, and it is the resistant to fluoroquinolone plus with resistant to any of the group A drug used for the treatment of drug resistant tuberculosis. The group A drugs include levofloxacin, moxifloxacin, bedaquinolones, and the linezolid. And there is also a condition added, that is pre-XDR TB, that is caused by Mycobacterium tuberculosis, which is DRTB, and then it is also resistant to fluoroquinolones. So we have to incorporate these new definitions, but for the old definition's sake, XDR TB. This is a crowded slide, indicates the diagnostic algorithm for diagnosis of tuberculosis. We can have a presumptive TB case in PALVA or in smear negative chest X-ray cases, previously drug treatment history case, and then we can have a diagnosed TB case. Now we can ask these patients to undergo molecular testing with gene expert. If R resistant is detected, then we can ask them to get tested with LIPA, and then we can determine whether there is a monodrug resistant or we are dealing with the XTR or pre-XTR TB. When rifampicin is sensitive, again we can go for LIPA and we can determine whether this is INH resistant or INH sensitive, and then we can decide our treatment on the basis of this. Any patient living with HIV, if diagnosed with drug-resistant tuberculosis, should be referred to PMDT sites, that is, site for the pragmatic management of drug-resistant tuberculosis. They will consider which ARV should be given, which can be combined safely with the second line drugs, that is, the drugs used for the treatment of drug resistant tuberculosis. And there is certain drug drug interaction that needs to be considered when prescribing ART with second line drugs. Just to give an introduction to the drugs used for the treatment of drug-resistant tuberculosis, they are divided into three groups and they need to be given in a combination. This regimen is decided at the PMDT site, but the group A drugs include fluoroquinols, linezolid, benedequine. Then the group B drugs include clofamazine and cycloserine. Group C drugs again include the drugs, but we need not remember these drugs. We just need to remember the principle of treatment, that we have to give the drugs which are not exposed previously for the treatment of DRTB. Regimens will be decided at the PMDT. What people at PMDT site do is they can give a short treatment regimen to the patient, which is for 9 to 11 months. Um, the intensive phase in this case can be for 4 to 6 months, and the continuation phase is for 5 months. And we can see that the intensive phase includes 5 drugs, 5 to 6 drugs, and the continuation phase includes 4 drugs. Then there is regimen 1 for the patient in whom the fluoroquinol resistant is is not excluded. Then again, this regimen is for about 20 months, and different combinations can be used. And then when there is fluoroquinol resistance, again the duration of treatment is about same. And when there is failure of MDR regimen, then again a combination of drugs can be given for up to 24 months. So these are the different regimens which are given at the PMDT sites. Since we are not giving it at the ART center, we need not remember these, but at least we have to remember the principles. And when the patient is coming to us for collection of ART, at least we should know that what this patient is receiving. We have come to the second I, that is initiation of the preventive therapy and the isoniazid preventive therapy. Now, who should receive isoniazid preventive therapy? All the adults living with HIV who are not having active TB, who are on antiretroviral treatment, who may be pregnant ladies, and who have been previously treated with tuberculosis. So all these patients are candidates to receive INH preventive therapy. Among children who should receive INH preventive therapy, all the infants less than 12 months of age who are having HIV and who are in contact with a person who is having tuberculosis. The children more than 12 years of age living with HIV, regardless of contact with TB patient, and all the children who are living with HIV who are more than 12 months of age, who may be asymptomatic, who are in contact with a TB patient, and whom TB is excluded. So for the initiation of anti-TB drugs prevention, that is INH preventive therapy, we have to exclude tuberculosis. What is the dose of INH given as preventive therapy in adults? It is 5 milligram per kg, and maximum up to 300 milligram can be given. In children, it is 10 milligram per kg, and again a maximum of 300 milligram can be given. INH preventive therapy is given for 6 months in patients who are having HIV, irrespective of the status of immunosuppression or whether the patient is on ART or not, and who is previously treated or is pregnant, all should receive preventive therapy. We have been talking about iris when we were discussing ART and ATT combination given together in the TB HIV co-infection. So what is iris? Iris stands for tuberculosis immunoreconstitution inflammatory syndrome. It is an unusually exaggerated immune response against viable or dead mycobacterium. It occurs frequently in HIV infected patients compared to the persons who are not infected with HIV, and it is an important complication of ART when, especially when it is given with anti-TB treatment. It is relatively common in persons who are started anti-TB drugs when the patient is on ART. Academically, it is divided into two forms. The paradoxical forms, when there is either the appearance of new lesions or deterioration of the pre-existing pulmonary or extrapulmonary tuberculosis lesion in patient who is receiving anti-TB treatment. It generally presents within 3 months of initiating antiretroviral treatment, and it is more common when the CD4 count is low. And the second form is the unmasking form, when the patient is not receiving anti-TB treatment when ART is initiated, and then it presents with active TB within 3 months of starting ART. So the TB disease unmasks when ART is started. So iris should be suspected when ATT and ART are given together, but the diagnosis of iris is not specific. It is the diagnosis of exclusion. We have to exclude superimposed infection. We have to exclude treatment failure. We have to exclude relapse. And we have to exclude the disease progression due to the drug resistant disease. So how to manage iris? It depends on the severity of the presenting symptoms. It can be just observed, and we can continue ART and anti-TB treatment, and the symptoms may subside on their own. We can give non-steroidal anti-inflammatory drugs in mild case. Then we can initiate corticosteroids, that is prednisolone, in moderate to severe disease. And very rarely we need to suppress ART for the sake of management of iris, and it usually occurs in a very severe condition. So what are the key messages? Tuberculosis is 19 times more common in patients living with HIV, so the presence of HIV and TB co-infection should always be considered. Therefore, all patients living with HIV should be screened for tuberculosis using the protocol given in the guideline. All patients diagnosed with TB should be started anti-tuberculosis treatment immediately. Those who are not diagnosed with tuberculosis should be started with isoniazid preventive therapy. ART should be started as soon as anti-TB drugs are tolerated, which is usually after 2 weeks and maximum after 8 weeks. Only in special cases like meningitis, we can wait for 8 weeks before starting ART. If the patient is already on ART, then anti-TB can be started without interrupting ART. If the patient develops drug-resistant MDR-TB, he should be managed at the PMDT site. All patients receiving concomitant treatment with ART and ATT should be closely monitored for iris. We have not discussed the third I because the infection control is dealt with in the other section. These are the references used for development of this section.